Afternoon, everyone. Welcome to the Maternal Health Echo, brought to you by the Center for Substance Use Training and Telementoring Center, or CSTAT, at Be Well, Texas, in collaboration with the Perinatal Psychiatry Access Network, or PeriPAN. My name is Brenda Macias, and I'll be facilitating our discussion today. I have just a few quick housekeeping notes before we begin. To help us with attendance, please enter your name, your affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. If you're joining via phone, please email your phone number and name to cstat@uthcsa.edu. We encourage everyone to join by video for the discussion portion in the latter half of the session. But no matter how you're joining us today, we're just happy that you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. There are a lot of us in this space, so please keep your comments brief to allow others the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or in our discussions. Our didactic today is on mental health, substance use, and co-occurring physical health conditions in perinatal populations, and will be presented by Dr. Anastasia Ruiz. Following that, we'll discuss a case also presented by Dr. Ruiz. We'll start with introductions, followed by didactics, announcements, the case presentation, and open discussion. Thank you again for joining us today. We'll start with some introductions of our hub team. So first, I'd like to welcome Dr. Adrienne Lindsay. Dr. Lindsay?
Hi, everyone. I'm Adrienne Lindsay. I'm the director for the Center for Substance Use Training and Telementoring here at Be Well, Texas, which oversees all of our ECHO programs. And I just want to say I'm excited that so many of you are here. We were thrilled by the response to this program. I know we've been hearing it from our community partners for a number of years that you all would like some more assistance in treating this special population. So thanks for being here, and we're excited to kick off our Be Well Texas PeriPAN collaboration.
Thank you, Dr. Lindsay. Dr. Mohammed Chaudhry.
Hello, everyone. My name is Ali, and I am one of the assistant professors at the Be Well, Texas. I'm also an adolescent addiction medicine physician, and I am working towards establishing an adolescent addiction medicine program here in San Antonio.
Thank you, Dr. Chaudhry. Joy Subrin.
Hi, good morning. My name is Dr. Joy Subrin. I am a doctor of behavioral health and a licensed master of social work, and I work in a co-located OBGYN practice, so they can have OBGYN care and also see a behavioral health provider at the same time. Happy to be part of the hub. Thank you all.
We're glad you're here as well. Emily Humphrey.
Hi, I'm a family nurse practitioner. I have done OB care with those with substance use disorders, both on the inpatient side and the outpatient side. And for the past 7 years, we was doing that in Austin, and now I am in Waco.
And Jennifer Erdegi.
Hi, I'm Jen Erdegi. I am the business operations director for Texas PeriPAN, the Perinatal Psychiatry Access Network, and happy to be here and launch this important series.
Thank you, Jen. Micaela Contreras.
Hello, everybody. My name is Micaela Contreras, and I am the PeriPAN program coordinator here with Texas Tech Health Science Center at the Lubbock campus.
Thank you, Micaela. And finally, our presenter today, Dr. Anastasia Ruiz.
Hi, everyone. My name is Anastasia Ruiz. I'm a psychiatrist physician. I am an assistant professor in the Department of Psychiatry at Texas Tech Health Sciences Center in Lubbock, Texas. I am also the regional director for the PeriPAN program for the West Texas region. I also supervise in our clinic. We have a perinatal clinic where we see patients every day, where I work with residents, and we are treating women that are planning pregnancy, pregnant, or postpartum. I'm so happy to be here with everyone today.
Thank you, Dr. Ruiz. We're excited about this presentation, and we'll get started with our didactic. Dr. Ruiz, whenever you're ready.
All right, I am ready. And are you perfect? I was going to say the screen wasn't popping up for me, but it is now. Wonderful. Today, the topic we will be talking about mental health, substance use and co-occurring physical health conditions in perinatal populations. And I also want to give everyone an education that we have also monthly webinar with a PeriPam where we dissect a lot of topics in detail, including how to diagnose, screen, treat different psychiatric conditions, and those are recorded in our PeriPam website. We will be sharing those links with you. Today, this topic will be a brief didactic, and we'll go over the case. Go ahead. Disclosures, all of our speakers and members, we do not have any relevant financial relationships with a commercial interest to disclose. And these are the views and opinions expressed by the participants and speakers attending the ECHO sessions are solely their opinions and do not reflect the office, position, or policy of UT San Antonio and the PeriPam program. Our 4 learning objectives today. Number 1, we will examine how pregnancy stress and physical health affect mental health and substance use in perinatal populations. The second objective, we will discuss the impact of untreated mental health conditions where it worsens physical health and perinatal outcomes. Third, we will review key findings from the U.S. Department of Health and Human Services Task Force on Maternal Mental Health. And fourth, we will highlight the ethical responsibilities to address both medical and mental health conditions in perinatal care using case presentations. So the first topic here, this is we all know this, and just to put it in some common examples here, how pregnancy stress and physical health can affect someone's mental health. Right. So if someone is going through medical conditions in pregnancy, that can add to stress for them, can worsen or precipitate worsening anxiety and depression. Some common examples I just listed here, for example, if someone has obesity and there is weight changes during the pregnancy, that can further worsen someone's energy level. They can have body image issues, maybe mood swings. This can impact their overall well-being. So a physical condition now is impacting someone's mental health. Another common example is gestational diabetes. It's very common. 1 in 10 women have gestational diabetes. We screen everybody for it. Now we know that if someone is not adherent to their treatment, there can be inconsistent medication adherence leading to fatigue, irritability, emotional instability. So again, a physical medical condition that is now worsening someone's mental health. Fatigue is very common in pregnancy itself. And so fatigue, if someone is not getting good rest or sleep and they don't feel rested, that further is going to exacerbate depression, anxiety. If someone has ADHD, bipolar disorder, all of those conditions will be exacerbated. Sleep disturbances of pregnancy. Again, the sleep is very important, and yet that sometimes is so difficult to maintain, especially when someone is pregnant or postpartum. We can also have chronic stress. Pregnancy is a very challenging stage for many because it's new, it's different, and there's added stress, financial stress. Who's going to watch the children? What about how will this impact someone's finances? It also has relationship stress. We have less time to balance. We may have less time for maintaining other relationships. And so all of this can really heighten someone's mental health symptoms. These are just some testimonies. We will be talking about the HSS task force report. I have that in the reference link as the first one, and that's a wonderful report. If you have time to pull up that report in detail, and in that report, they included some testimonies that they presented to the Congress. I want to share some of these testimonies from real women here, and I think it's really relatable. Number 1, all this stuff happened postpartum for me. It was all in my chart, and I was having issues breastfeeding. I was calling my midwife a lot, and that was difficult for me. Being postpartum, having medical issues with my son, and having medical issues of my own. So in this case, you see someone was having breastfeeding issues, then their child had medical issues, and so this is impacting their mental health. Second example, I feel like a fish out of water. You're not supposed to have a baby and get diagnosis of PTSD. It's not uncommon to have traumatic birthing experiences. So now we have an added mental health distress on top of recovery of the physical trauma. Third example, between chronic pain and insurance, I couldn't find someone who had availability, so it fell by the wayside. I was trying to juggle it all. It got really bad. My mental health got bad again after she turned 1. She's screaming and crying when she should be sleeping. I was spiraling and taking it out on my partner and being mean. I did not want to be here. Maybe my child would be better if she didn't have a mom. It was a really hard time justifying why I should be around my husband, my daughter. So if we the essence here is that if someone is going through any kind of medical complications, we have to reflexively inquire and follow up with your mental health. Now, the next slide, we will talk about how mental health, on the other hand, can worsen someone's physical health. We know that depression and anxiety during pregnancy are linked to various adverse pregnancy outcomes. Women with psychiatric illness during pregnancy are less likely to receive adequate prenatal care. They are more likely to use substances, including alcohol, tobacco, etc., that then negatively impacts the pregnancy outcomes. We will also have adverse outcomes for infants, including low birth weight and fetal growth retardation, increased risk of preterm delivery. Pregnancy complications can also be associated with maternal depression anxiety in the late pregnancy. This includes higher risk of preeclampsia, increased likelihood of operative delivery, and greater risk of infant admission to special care nursery for respiratory distress, hypoglycemia, prematurity. So when somebody has any mental health diagnosis, complications during pregnancy, not treating in and of itself is a risk alone. So a lot of times moms may be worried about the stigma of receiving treatment during pregnancy. They may feel that not treating their mental health condition would be better for their children and their pregnancy by limiting exposure of medication per se, but that is just not the evidence. The evidence is not treating also carries a huge risk, and for many, that risk of not treating is higher than the risk of the treatment. Here are some statistics here of untreated mental health conditions. We know that up to 20% of women experience mood or anxiety disorder during pregnancy. 20%. So this is double the rate of gestational diabetes. We screen everyone for gestational diabetes for 1 out of 10 women. And for anxiety and depression, that's 1 out of 5. So we really need to be screening every woman for their mental health symptoms during pregnancy. We know that those with depression and anxiety who discontinue antidepressants are 5 times more likely to relapse than those who continue treatment. We also know that those with bipolar disorder, which is a severe mental illness, who discontinue their mood stabilizers are 2 times more likely to relapse at a 85.5% relapse rate, and often within the first month of discontinuation. So we are constantly educating our patients about the risk. What is the risk of not treating? Here is a slide. So these are good numbers to memorize, to share with our patients. We also want to educate about the risk of treatment. And when we talk about risk of psychotherapy, the risk is generally pretty low, but it does include the time and financial burden. When we talk about risk of medication treatment, that risk would include exposure of the medication to the fetus or through breast milk postpartum, and also potential risk of the medication's impact on the pregnancy. And we use the PLLR tool, pregnancy, lactation, and labeling rule. I presented on how to use this tool in the January webinar lecture, and I encourage everyone, if you have time, you can watch that. If you two-speed it, it's only 30 minutes, so it shouldn't take you that much time. I teach everyone how to look up that information. And this is a big tool. It comes in the app. You can go to many different websites. We can print out handouts for our patients about the risk of medication treatments and the benefit. Next. I want to go over a few very important facts here that was detailed in that HHS Task Force on Maternal Mental Health report to Congress. I reviewed that report, and here are some really important facts here. Number one, the overdose mortality in pregnancy. Okay, and surprisingly, in late postpartum, this is important because we often are very good at screening for women 1 month postpartum. We are so good at following up. This is the data. It is very scary. Actually, the risk is higher past 6 months postpartum. Higher overdose mortality rates are observed in late postpartum women. This is beyond 42 days after pregnancy. And here's a comparison. 36% of deaths occurs between 43 and 6 months postpartum, while 47% are more than 6 months postpartum. So only a minority of the mortality occurs within 43 days postpartum. That's when we screen the most. We are so aggressive. We do it in the hospital, we do it in that first follow-up. And this data reminds us that we do not need to stop screening and asking about psychiatric symptoms. Even if someone is 6, 7, 8 months postpartum, we need to be doing it up to 1 year. We hear this quite often. Women would tell us, I was screened for depression, anxiety, and I screened negative. And yet my symptoms came later and they fell through the cracks. So when we're making those appointments, we need to make sure to extend regular follow-ups for women that have those medical and psychiatric risk factors. And addressing mental health, substance use, and their impact on maternal mortality in their late postpartum, we need to remember that the burden of screening is beyond the initial visits. We need to continue to screen within that first year postpartum, even beyond that. Hopefully, everyone can have a longitudinal relationship with their patients even beyond the 1 year. We also know that pediatricians and PCP play a crucial role in the screening because when moms are busy, they will forego their OB follow-up. Often they'll have that 6 weeks follow-up and they may cancel the other ones. They may not go back and see their OB when they're busy. However, the baby would need their regular follow-ups. So the pediatricians and PCPs share an important role in asking parents about their mental health when they show up for their checkups. Because we need when the baby shows up for their 6 months, their 9 months or 12 months, we need everybody to be asking the mom how they're doing. We don't want to forget about fathers. Fathers also have a risk of 1 out of 10 risk of postpartum depression. So if fathers are present, that's a great time to check in on fathers as well. The number one risk factors for fathers having postpartum depression is if the mother has it. So that is make sure we're checking up with everybody. We don't want to forget about our patients that experience fetus or infant loss. So that if there's no baby, that's a huge trauma. And yet we forget about them because there's no follow-up appointment. So we need to be conscientious of following up with our patients that had a loss. Okay, next. Second important factor outlined in that report, substance use and mental health. Prevention of pregnancy-associated deaths are important. We know that women with substance use disorders, particularly opiate use disorder, they face a higher risk of pregnancy-associated death. Timely intervention focusing on co-occurring medical health conditions is very important alongside the substance use treatment. We have to treat both. Substance use often is secondary to another underlying mental health condition, and we need to be treating both to make sure proper recovery. Next. Number 3, in that report, they list some data that was pertaining to Texas. Okay, they had a Texas study that was included in the report. What they found in that there was complex needs of women in recovery. Women with substance use and mental health disorders, they often experience multiple traumas, abuse or loss of a loved one. They often have untreated mental health conditions, and they often have a lack of social support. We know that postpartum substance use is more prevalent among women with mental health disorders and those with adverse childhood experiences or stressful life events. So if you know your patient's story or have time to get to know their childhood, their past trauma, those are important because trauma is a huge risk factor for substance use. We know that the loss of custody of children increase the risk of substance relapse and overdose. This emphasizes the need of integrated care addressing mental health, substance use, and physical health. Here is a quote from a mother that was included in that report. I was terrified my kids would be taken away from me if I told my midwife or doctor what was going on with me. So there's a lot of fear and stigma of our patients. And another thing is when children are taken away, that it is a critical time of risk for relapse. So that's another thing we need to keep in the back of our mind. If this event were to occur, that CPS is involved and children taken away, we need to make sure the patient is being checked up and follow up regularly so that they do not relapse, losing the further worsening their chances of reuniting with their family. Next. So earlier I talked about how substance use is very common. It's comorbid with another mental health condition. And I think this is an important fact for ourselves as the clinician, the patient-facing specialist, to get rid of stigmas ourselves. Okay. I think everyone probably know somebody you care about that struggles with substance. So this is easy to understand from that perspective. And I encourage everyone to think through those lenses of this patient who has a substance use issue. You know, think of someone you care about that struggle with that. And that often helps us get rid of any biases or transference or any burnout that we may be expressing onto the patient. We need to understand that the trauma, adverse childhood life experiences, depression, anxiety, those are huge factors that is driving that behavior. And if we can see it through those lenses, we ourselves have more empathy, and that empathy can be contagious onto the patient and their family. So that's really important that we start with ourselves. Early screening and intervention for mental health and substance use during the perinatal period can reduce risk of physical health complications. So if your goal is to provide your patient with a healthy pregnancy, we cannot forego screening and treatment of their mental health and their substance use history. That would give us a healthier pregnancy, decrease mortality and morbidity for mom and family. But also, there's probably other children around the household. So this work here in maternal mental health is transgenerational. You are impacting multiple lives in one visit. Okay, next. There are some, in that report, it talks about barriers to treatment in rural areas. We found that rural women face significant treatment barriers for both substance use disorder and mental health conditions. This includes a limited access to medication-assisted treatment and stigma. And we have a lot of rural areas in Texas. And so this is an important thing we need to focus when we're looking at improving access to care for our state. These challenges are compounded for pregnant women because of legal concerns and child custody fears. So we definitely need accessible integrated care in rural areas to address these concerns. And this is where Be Well Texas and PeriPAM, we aim to address the stigma. Both of our services have telehealth services. And if you are in a rural area, if you're a clinician or someone that's working in a rural area, the responsibility really falls on you to really be asking and screening and getting to know your patient well, because you may be their only person they talk about their symptoms to. Okay, next. This is the last slide in our presentation today. It just goes back to that ethical responsibility to address both medical and mental health conditions. One thing that I hear commonly from people that call me up about what they can do is that they see there's a problem, their gut is telling them they need to ask more, but then there is fear that maybe this is not in my responsibility. Maybe this is out of scope for me. I hear that quite often. But with the facts present today, with the state of urgency with this issue, with mental health and substance use being the number one cause of death, mortality, but the top mortality cause for pregnant women, postpartum women, um, the responsibility falls on everybody that is seeing the patient. Here's a great quote I just love from Hippocrates. Healing is a matter of time, but it is sometimes also a matter of opportunity. So if you have an opportunity and you come across a patient who you think is at risk, that is your opportunity to address, screen, and treat. We know that referral time is significantly impossible to get someone in quickly. Not to mention there's transportation issues, financial issues. So there's all these barriers that gets in the way and patients don't get care. If we don't intervene right now, the likelihood of them getting services later is slim. In the perinatal population, there are numerous opportunities for patient-facing clinicians to aid in the healing. Asking about someone's mental health is part of that treatment. You just asking about it, just that question from the nurse, from everyone that sees a patient itself is part of treatment. Here's a quote from a patient, a mother of two. She said, being asked about my mental health made me feel that mental health and emotions were a legitimate concern. During our last webinar 2 weeks ago, this is recorded. If you want to review that, I have the link right there. We talk about the ethics of treating mental health conditions in pregnancy and the postpartum period. And we talk about the ethical imperative that timely treatment is essential. So if you are someone's PCP, if you're their pediatrician, and if or anyone that is noticing someone needs to be screened and treated, but you're not quite sure where to start or how to do that, give us a call. Give us a call at PeriPam and we will help guide you. We will give you tips, screening tools. If a patient needs to be seen, because we're not quite sure what's going on, we have a direct consultation survey that's free of charge for patients and for your clinic. And we can see the patient within 1 to 2 weeks through telehealth. We will have a comprehensive evaluation, screen for mental health conditions, and screen for substance use history, and call you back then about what to do. Okay, so with this service, we don't take over care, but we help you continue the care, and we help you start care right here, right in your office. If a patient is needing to get in with a psychiatrist, we can help you figure out how to do that, but also get the patient treatment at this time without having to wait 2, 3 months. Sometimes it's longer than that. So we want to make sure that the patient does not fall through the crack. We also help you get resources for education for patients, family, and for DCOLR. And we are collaborating with Be Well Texas, who are the experts of substance use treatment. So if anyone is if you need any tips, advice about how to screen or treat, we are collaborating with Be Well to get you the most up-to-date evidence-based treatment strategies. They also have a program where they can see patients as well and get started on treatment. All right. Here's the references I share with you, and these are all amazing references. I encourage you, if you have time, to go ahead and open the link and look through those reports.
Thank you, Dr. Ruiz, for that content and that presentation. We don't have any questions yet in the chat, so we welcome anybody who does have a question to either drop that question into the chat or to unmute your mic and ask that directly right now, or ask that aloud right now. We did have a question regarding the slides, and yes, this information will be available on the content tab of iEcho after this session. We had a few comments from one of our hub members, Dr. Subrin, about PSI, Postpartum Support International, having several support groups, online support groups for both moms and dads. That link has been shared in the chat as well. And that asking for help normalizes mental health. And so all of you have a wonderful opportunity to close those gaps, to build bridges, as she said, for your patients.
I turned my mic off. Is that okay? This is my first hub, everybody. So I am just like your patient who's walking into the office for the first time, right? Nervous about sharing, feeling a little judged. So I'm in their shoes. I'm Joy. I'm a doctor of behavioral health, like I said, and I'm speaking as loudly as I can. I'll have to get a headset. I just couldn't help myself but sharing because it is about gaps. It is about identifying what little steps can we move forward. Maybe you live in a rural area where there isn't a support group or a MAP program or a home visiting program, but you know somebody in Arizona who runs one, or you know somebody in the county over. I'm just a strong believer that this room full of 160 people can help our patients move from contemplation to stages of change for their health and for their real quality of life. And I love the term that Dr. Ruiz said. Hold on, I wrote down 5 pages. It's that it's just that transgenerational care. That's pretty powerful. So if you've got we all are guilty of that stigma of what we expect from this patient because it went one way or another, the last patient. Please let that drop when you're meeting with these patients because they deserve our care and our empowerment.
Thank you, Dr. Subrin, and thank you for your wonderful experience. And we thank you for being a hub member. We still are looking for questions from our learning community. You can drop those into the chat or you can unmute and ask those aloud.
Hi, my name is Amanda. I don't have a question, but I did want to say like when she said about like the MAP programs, like postpartum mothers without the MAP programs. So I used to be a substance abuse user, and then I had my daughter, and straight after that I went to rehab. And if I wouldn't have had that MAP program, like I wouldn't be where I am right now without that. So it is like it's good to be in and to be able to hear webinars like this or stuff like this because at least I know I'm not alone.
That's awesome.
Thank you, Amanda. Go ahead, Shalisa.
Amanda, I just wanted to say, sorry, this is Dr. Wakefield. I'm the medical director for PeriPan. Thank you for sharing your personal experience. You're brave and we appreciate that. And we appreciate everybody who's here listening today.
Thank you, Dr. Wakefield. Thank you, Amanda, for sharing. And Miguel has a comment in the chat. You can look for PPI programs in your area. I know the support groups have been beneficial for our moms in this area. And our regional PeriPan teams can assist you with locating support for your patients. A simple call or a text is all it takes. Thank you for these comments. Keep them coming in the chat or unmute your mic and comment aloud.
Hello, my name is Catherine Johnson. I work with University Health. I just wanted to share, after conducting some of the focus groups for our maternal health grants related to the mental health topic that we're talking today, when asking some of the moms and their experience, 2 things came up about screening, that they felt like, what's going to happen after? What if I do say that I'm depressed or that I'm sad or that I have anxiety? So I think it's important to educate them that it's a safe space and, educate them on the steps of what's going to happen if I do say yes. Because there are fears of, are they going to take my baby away if I share this experience? And then just another point, some of the screening questions were that, at least their experience was that were very basic. Like, I think that we need to get to develop a relationship with the patient so they feel more comfortable because they might not want to say that they're sad today, but maybe next visit they would. And then just go beyond the questions because sometimes, they may not feel quote unquote depressed, but related to depression, if that makes any sense. So I just wanted to share that as well. Thank you.
Thank you, Catherine. And just in the interest of time, we're going to move forward. Dr. Ruiz, we have about 4 questions in the chat. If you could please review those questions and respond to them if you can. And so we'll move to our announcements now. And I'm going to get those slides. Thank you. To receive credit for today's session, participants must have an active account with the Texas Tech University Health Sciences Center Office of Accredited Interprofessional Continuing Medical Education Office. You can create an account by clicking on the link that is provided in the chat, or you can go to iEcho and find the instructions on how to receive credit document that's been posted to the Content tab. Participants are eligible to receive up to 1 hour of credit based on the duration of your participation, and those increments are listed below. If you have specific questions about CME credits, we encourage you to email or call the TTU HSC CME office directly. And I'm going to hand it over to my colleague, Micaela, who has an announcement for you regarding our CMEs.
Yes, we would like you to please let us know how we are doing by completing our evaluation. You can scan the QR code, which is on the screen, or click the link that will be provided into the chat. This evaluation will be available until 11:59 p.m. on Wednesday, April 30th of this year. If you have already your account set up with the TTU HSC CME office, you can use the text and attendance feature with the code 39648 to phone number 844-984-4767. The text code is only available until 11:59 p.m. today. And also please remember that in order to receive your CME credits, participants must have a My Portal account set up with the Texas Tech University Health Science Center Office of Accredited Interprofessional Continuing Medical Education Office. Please refer to the documents on the link that will be provided into the chats.
Thank you, Micaela. And that session evaluation will be available and active at 1 p.m. today following today's ECHO session. And so now we ask all our learning community, do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and to receive feedback from our hub of experts and broader learning community. There's no need to prepare a formal presentation. We'll provide a case form to fill out to assist with your presentation. If you're interested, please email us at cstat@uthcsa.edu. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form at cstat.uthcsa.edu/contact-us, and we'll be pleased to help you. IT will drop that link into the chat as well. And now I'm going to turn this over to Jen Ertegy with PeriPan of Texas for our final announcements. Jen.
Hi, I'm just going to provide a brief overview of the Texas Perinatal Psychiatry Access Network, known as PeriPan, which is designed for clinicians who see pregnant and postpartum women. It was created to address the maternal mental health crisis. Mental health conditions are the most common complications of pregnancy and childbirth, affecting 1 in 5 perinatal women and ranking among the leading cause of pregnancy-related death. A lack of access to care and provider shortages further compound this problem. PeriPan has 4 major components, as you see on the slide, and we provide clinical guidance to help with a single patient case or enhance mental health care in your practice as a whole. Next slide. PeriPan is anchored by 12 regional medical schools and health-related institutions across Texas, as you can see on this map. Signing up is easy, and you'll reach a mental health expert by phone and can consult with a reproductive psychiatrist within 30 minutes or at a callback time that you choose. Anyone in your office can call or text to start a consult request. So each region does have their own unique texting number, which is provided at sign up. You can call the number on the screen to enroll. Next slide. And we'd love for you to join us for the PeriPan webinar series, which are held on the 3rd Tuesday of each month. These sessions complement the ECHO series, offering deeper insights into perinatal mental health. So on the screen, you'll see a list of upcoming topics and dates. Be sure to register and stay informed. Connect with our experts and expand your knowledge. We look forward to seeing you there. And then I think our last slide is just a list of topics for the upcoming lunchtime maternal mental health ECHO series, which are held on the 1st Tuesday of the month. We invite you to join us in future sessions to continue learning about these important topics and engage in discussions that support perinatal mental health. Thank you.
Thank you, Jen. And with that, we're going to move to our case presentation today. Dr. Ruiz, if you would please walk us through that case.
You're muted, Dr. Ruiz.
Thank you. Okay, thank you. I wanted to spend a minute real quick answering a really good question I saw. It says, what is the use of screening questionnaires in the initial OB visit and the benefit of treatment as we get assistance from specialists? This is a great question. And this is something I still teach my residents about every minute, every day of an untreated or undertreated mental health condition is devastating. I include a picture here of a neuron under stress, and you see the impact of stress on a neuron, and there's billions of neurons in your brain. It looks like a tree that's been winterized, lost all its branches. And we see this regularly. Every day of untreated mental illness will take longer and longer to recover. And one day of missing work, 2 days of missing work, now you don't have a job. Now you're evicted from your home. Maybe now you are relapsing. Maybe that relapse turns deadly. So every second is crucial. And by screening in that initial visit, you are giving the patient that opportunity to call you and be open to you. That's key. Even if the appointment's a month away, that month can be life changing for that patient and life saving for the person that is able to connect with their patient. All right, very good. Okay, so here's the case here, and here's the case form. I just want to read you the case real quickly, so follow with me. We have a patient who's 30 years old. She's G5P2, 28 weeks pregnant with her fifth pregnancy. She does have a history of 2 infant losses. She has a past medical history of obesity, gestational diabetes. She's currently being managed with metformin and insulin. She also was diagnosed with bipolar disorder in her teen years. And she also has reported childhood adverse experiences and sexual trauma. She's 30 right now, but when she was 20 years old, she did have a period of methamphetamine use, and it was causing debilitation to her life. And later, she also had opiate use disorder. At this time, she had 2 young children. Her children were removed by CPS. She went to rehab. She maintained sobriety, and she regained shared custody of her children with her ex. So now she's living with her husband in a healthy relationship. Her children are 12 and 10 years old. She is overall the last 10 years she's done very well. But now that she's pregnant, she's got increased stress. She's got diagnosed with gestational diabetes, but she finds herself not motivated, tired, depressed, anxious. She is not taking her medication consistently. She's forgetting them. She's dealing with stress about custody issues with her ex, in-laws, as well as her children are having behavioral issues, and one of them was recently diagnosed with ADHD. So with all of that, she comes to you, and she maintains sobriety. She's motivated. She does share with you that she started vaping 3 months ago. Now, she's 28 weeks pregnant. She knows it is not good for her pregnancy, but she finds it to be helpful to decrease her anxiety and help with her focusing. So this is a case here. 10 years ago, she did not receive medication-assisted treatment. She went to a rehab program, and she was able to maintain sobriety with therapy and treatment of her depression. She presents to you, she's high risk for relapse. And she also is having complications of the diabetes. The question is, what do we treat first? Do we treat her diabetes because she's feeling so tired? Maybe that will help her feel better. Do we go ahead and also explore her mental health condition? Do we offer medication assisted treatment? What do we do with this case? And I will let Be Well take over and help us discuss this case.
Thank you, Dr. Ruiz. An interesting case for sure. So now we open the floor for questions, for insights from our learners that may provide valuable insights for this case. You can drop those into the chat, or you can unmute your mic and share those aloud.
please provide me with a deep.
So, Dr. Ruiz, you said that you want, and we had some discussion earlier just about this case, treating the medical or the psychiatric symptoms first. I think that we had some wonderful insights from Dr. Subrin. Dr. Subrin, would you talk to us a little bit about asking the importance of one, or how one can activate the other, and the importance of our patient kind of advocating for herself?
Yeah, thanks for the floor. I just know there's 156 people who are just like me, afraid to come off the mic. But I think that you and our team agree that it isn't about one before the other, it's the blend. And I think sharing that with your patient is really empowering. It's saying we're multidimensional. One factor impacts the other. They're all health behaviors, right? Substance use, vaping, those are health behaviors. Taking our meds or not taking our meds, or eating right or not eating right, those are all health behaviors. So I would first want to share with the patient, that's our lens as your team. I also mentioned in our pre-conference time that I like to use the empowerment model, that this is the patient's care, and she's in the middle. She's family-centered, she's patient-centered. So I would want to say something like, I have a lot of goals to help meet some of your health needs. What's most important for you today? I want to destigmatize the conversation about mental health and about substance use. Where do you want to start? So I think sharing with the patient that they are interconnected, and we see it that way, could kind of be a real shift for that patient. So I hope some of you agree.
Yes, thank you. So we've got quite a few comments and questions in the chat. So from Rebecca Serrano, is she willing to start and maintain psychiatric treatment? From Stacy Marlin, what medications currently is the patient taking, and what has she taken in the past that worked or did not work? Dr. Ruiz, I'm not sure if you know any of these, the answers to these questions. Anila Brown says, validating that she has a lot going on and she's trying to navigate as best as she can. Perhaps asking if there were any healthy coping strategies that she has tried in the past that worked, and maybe encouraging her to continue with those healthy coping. And then Samantha Heinley says, pre-planning for managing bipolar disorder symptoms before birth. We know that the inconsistent schedule of caring for a newborn can for manic or depressive episodes. Thank you for those comments. Keep them coming.
And those are such good questions. And those are the exact questions that we want everyone to feel comfortable asking in your visits. And this is a typical case of so complicated. And you may have to spend so much more time asking about the diagnosis. Is this right? There's so much questions. There's so many family history. This is a perfect time to call PeriPam and say, I got someone that's very complicated. Can we go ahead and get them to have a direct consultation? Because we will sit down with your patients for a comprehensive assessment that often takes an hour and a half. We go through all of that, make sure we have the accurate diagnosis, and we call you back, say, hey, this is our summary. This is what I would recommend treatment. So if you find yourself being stuck and not sure where you're at, because this is outside of your typical treatment specialty, call us. We want you to ask those same questions, have the gut feeling like, okay, this woman needs more. I'm Nicole Perry-Pam, and that's why our program is here.
Yeah, along those same lines, I think as a clinician, you have 15 minutes to maybe see this patient and it's super overwhelming. And so I go back to simplicity. You know, where is her fatigue coming? Is it from her diabetes? Is it from her depression? Who knows? Like, right? I'm not going to figure that out in 15 minutes. And so I like the idea of kind of approaching this like, Let's try to get her sugars under control. Ask her what antidepressants worked in the past. Keep it as simple, and consult someone else that can spend an hour and a half doing a consult, rather than trying to rush through this. And at the end of the day, feeling like you weren't able to fully assess it, because that's never a good feeling. But I think clinicians are under a lot of pressure to see people quickly. And this is someone that you can't do that with. And so to reach out to those resources.
Thank you. We've got several more comments in the chat, including a request for completing the post-session survey. That link is available in the chat. We encourage you, all of our participants, to continue dropping comments and questions in the chat. And so just in the interest of time, I'd like to move on to recommendations. Dr. Chaudhry, could you please give us a summary of these recommendations?
Yeah, absolutely. I think one of the things to recognize is that, first of all, we need to normalize having these symptoms in pregnancy. So talking about that, like, just letting the patient know that it's going to be okay, and we're here to support you. It just puts the patient at ease and builds that rapport in which they can share these symptoms with you, and then you can deal with it in a better way. Number two thing is, it's always important to take a parallel approach to treatment for the physical health symptoms and the mental health symptoms, because in most of the cases, they actually feed on each other. So untreated mental health symptoms can lead to bad pregnancy outcomes, and vice versa. So it's important to address both of these issues in parallel. And the third thing that's important is, it's okay to have limitations. And we understand that, when you're providing OB care, you're under a lot of stress. There's a lot of other things you need to manage. So do the best that you can, get the information that you can, and always know that there is someone that there is always someone who can help, be it in the form of Beeville, Texas, or in the form of Peripan, people who are specialized in this field, and who have more time to spend with patients just regarding these issues. So always feel comfortable just getting either a curbside or getting a full consultation for the patients with regards to these complex cases.
Thank you, Dr. Chaudhry, for serving as our lead expert today and for that summary of these recommendations. We had another comment that I'd like to call attention to from Anila Brown, appreciating what Emily Humphrey said. It does take a team. And if you acknowledge as a provider what you can do and who else is part of their care, the patient won't feel like they were just ignored or disregarded. It echoes what Dr. Chaudhry just said. And I had another question in the chat about receiving credit for today's webinar. There is a PDF document called Instructions on How to Receive Credit. It is uploaded on the content tab of iEcho for today's session. There's specific instructions on how to set up an account with My Portal. And we want to thank everybody for joining today's maternal health.
It's about how dads can have postpartum depression.
Brenda, I will say there's a new question in the chat that maybe we want to try to answer if we have just a couple minutes, or
we've got time. From Sangeeta Jain, any experience with medications for bipolar or antipsychotic safety in pregnancy? I'll open that up to Dr. Ruiz, to Dr. Chaudhry, and all of our learners on this call today.
Yes. Because this is what I do, so I'm very comfortable with it. And there is quite significant safety data for continuation of medications for bipolar disorder and antipsychotics in pregnancy. The one that we should avoid is Depakote valproic acid, because of the high risk of neural defects and developmental disorder. But aside from that, and then carbamazepine is the second mood stabilizer that should be cautiously avoided. Other than that, all other medications, the safety data does not cause teratogenic effects. There are risks to be educated with the patient. Mother to Baby.org is a helpful website. Infant Risk app It can be downloaded with a small cost as well. And within that data, what you'll find is information about the safety, the studies that's on it, the side effects to be aware, and a laboratory to monitor for. In general, the rule of thumb is what kept a woman well will keep her well through pregnancy, and we should continue treatment.
And if I may, I'm going to add to that, Dr. Ruiz, thank you so much for the answer. I will say that no one likes to do studies on pregnant women, if you haven't noticed. And so we don't have a lot of studies that show in randomized placebo-controlled studies that have a woman who is pregnant on one medicine and another one who is not on that medicine, and comparing outcomes in the future. What we have is a lot of retrospective reviews of women who are prescribed different medications. But what's the most important thing, and that I wanted to echo and amplify that Dr. Ruiz just said, was that the goal is to keep mom well. That is the goal, that we know that that is so very important in baby's development and health in the future, and baby and mommy bonding in the future. And we want to keep mom well. And so whatever we need to do to keep mom well. And of course, we want experts involved when we're making these types of decisions, but there are times that we use medications that otherwise we wouldn't start in pregnancy. But if that is what has kept mom well, we need to use what has kept mom well. And so that's our primary focus in pregnancy and postpartum period, is how important it is to keep mom well.
Thank you, Dr. Wakefield. Another question that just came up, which we have time for: what about for patients that have psychosis that is induced by pregnancy? This person had a client who every time they became pregnant, they would start having increased symptoms of psychosis and persecutory delusion. Sorry, having trouble with language.
So this is if this is a pattern of postpartum psychosis, we need to make sure that they are treated, maintained on prophylactic medication in pregnancy that's continued through postpartum. The most evidence-based medication for this is going to be lithium. Now, every patient's case is complex, it's different. So we need to consider that this patient will require a collaborative team care with close monitoring. Another thing I'm thinking is, is this outside of pregnancy? Do they have something like a severe mental illness, such as bipolar disorder? So this is a high risk patient that would need a close monitoring.
Thank you, Dr. Ruiz. And I'd also like to encourage Christian to submit that as a case. That sounds like a wonderful case to present to the learning community. You would receive real-time recommendations, consultations about this specific patient, and you would get all of those from the entire learning community, which today was 162 people. And so we thank all of you for joining us today. We thank Dr. Ruiz for presenting today's didactic and case presentation. We thank all of you who are still here for the Maternal Health Echo, to all of our Hub team members. As a reminder, to earn CME credits, please complete the evaluation using the link in the chat. The CME office will also email all of you with the evaluation survey. If you have a case or scenario that you would like to share, please email the CSTAT team at cstat@uthcsa.edu. We look forward to seeing all of you at our next session on Tuesday, May 6th at 12 p.m. Central Standard Time. Have a great rest of your day. Have a great week, everyone. Bye-bye.